Today, we're diving into a medication that has been a lifesaver for millions. But taking it is like walking a tightrope. It's called warfarin, and to understand it is to understand a constant, delicate balancing act.
And that question really gets to the heart of the warfarin story. It is an incredibly powerful weapon against deadly blood clots, but one tiny misstep can be dangerous. So how in the world do doctors and patients stay on that rope?
All right, so before we can really get into the solution, we have to understand the problem. I mean, why would anyone need a medication that makes them bleed more easily? Well, it all starts with the very real danger of blood clots. Now, usually, clotting is our friend, right? It stops us from bleeding when we get a cut. But sometimes our bodies form clots on the inside, where they shouldn't be, in our veins or arteries. And when they do that, they can act like a roadblock, cutting off blood flow to critical places like the lungs, or they can break free and travel to the brain, causing a stroke.
And this isn't some super rare thing. Doctors prescribe these drugs, anticoagulants, for a whole range of serious conditions. We're talking things like deep vein thrombosis, or DVT, atrial fibrillation, which is an irregular heartbeat that can let clots form inside the heart, and even for people with mechanical heart valves, which are just magnets for clot formation.
So, to fight these dangerous clots, for over 70 years, one of the go-to drugs has been warfarin. It's a hero in many ways, but the very mechanism that makes it work is also what makes it so incredibly tricky to manage.
So what is it really? Well, simply put, warfarin is a vitamin K antagonist. Think of vitamin K as a key ingredient your liver needs to cook up clotting factors. Those are the proteins that actually form a clot. Warfarin's job is to mess with that recipe.
And how it does this is actually pretty clever. It doesn't just destroy vitamin K. Instead, it blocks the enzyme that recycles it. So, by cutting off this recycled supply, it slows the whole production line way down, making your blood less likely to form those dangerous clots. But here is where it gets really weird. Warfarin doesn't work right away, and in the beginning, it does something you wouldn't expect. In the first few days, it actually knocks out some of our body's natural anti-clotting proteins first. This creates this bizarre little window where your risk of clotting might actually go up before it goes down. It's not until about day 5 or later that the pro-clotting factors finally drop enough to do what we want. This quote right here nails that early danger. That transient hypercoagulable state is just a fancy way of saying a short period where your blood is more likely to clot. It's wild, right? And it's exactly why doctors often bridge patients with a faster-acting drug like heparin for those first few days. It's like a safety net for that risky startup period. Okay, so if this drug's effect is so delayed and variable, how on earth do doctors keep track of it? How do they know if a patient is protected or too protected? The answer lies in one absolutely vital blood test. And that test is called the INR, or International Normalized Ratio. The concept is pretty simple. It's just a standardized number that tells us how much longer it's taking for a person's blood to clot compared to someone who isn't on the medication. To give you some perspective, if you're not taking a blood thinner, your INR should be right around 1.0. That's our baseline, our starting point. The whole goal of warfarin is to push that number up into a very specific target zone. And that target isn't the same for everybody. For most conditions, like a DVT or atrial fibrillation, the goal is an INR somewhere between 2 and 3. That means our blood takes 2 to 3 times longer to clot than normal. For higher risk situations, like with mechanical heart valves, that target is even higher, up between 2.5 and 3.5. That little sliver of a range, that is the therapeutic sweet spot. And this is the tightrope. If your INR drops too low, your blood is too thick and you're not protected from clots. But if it goes too high, your blood becomes too thin and the risk of a serious bleed goes through the roof. Staying inside that narrow little window is absolutely everything. You know, it would be hard enough if you could just find the right dose and call it a day. But the real challenge with warfarin is that dozens of everyday things can nudge a patient's INR up or down, threatening to push them right off that tightrope. And this gives you a great idea of the main culprits we're talking about. It's what you eat, other meds you might be taking, whether you get sick, even your own genetics can change how your body handles the drug. Let's start with food. Since warfarin is fighting vitamin K, it makes total sense that the amount of vitamin K you eat can throw things off. If you suddenly eat a giant salad packed with spinach and kale, you're giving your body extra ammo to work against the drug, which can drop your INR. So the key advice for patients isn't to avoid these foods, it's to be consistent. Then you've got other drugs, and this is a huge one.
Starting a simple antibiotic can make your INR shoot up, seriously increasing your bleeding risk. Other drugs can do the exact opposite. And then you have common painkillers like ibuprofen. They don't even change the INR. They just increase your risk of bleeding on their own, which is a dangerous combination. And finally, your own health plays a massive role. How well your liver is working is critical, since that's where the clotting factors are made. Just getting sick with a fever or having a flare-up of something like heart failure can send a perfectly stable INR completely off the rails. It requires constant monitoring.
So, with all these things that can go wrong, what happens when a patient does fall off the tightrope? What happens when their INR gets dangerously high and they're at risk of bleeding? Well, fortunately, there are very clear protocols for these emergencies.
Let's be crystal clear. The number one risk, the biggest adverse effect of taking warfarin, is hemorrhage, major bleeding. That is the danger that doctors and patients are constantly trying to avoid.
So in an emergency, the response is quick and follows clear steps. 1. Stop the warfarin. Just hold the dose. 2. Give the direct antidote, which is vitamin K, usually through an IV for a fast effect. And 3. For a really life-threatening bleed, doctors have a trump card called 4-factor PCC. It's basically a concentrate of the clotting factors that warfarin was blocking, and it works fast.
You know, warfarin has saved an incredible number of lives, but it demands so much from both patients and doctors. And with newer anticoagulants now available, ones that don't need all this intense monitoring, you have to ask the question, after more than 70 years, is the era of walking this particular tightrope finally coming to a close? That's one of the big questions in medicine today.